The ICF Training and Technical Assistance team is honored to welcome you to this California Housing and Community Development training session offered through the Emergency Solutions Grant Coronavirus Relief Consulting and Staffing Services Contract. I am Chris Pitcher with ICF, and I'll be your host today. Today's session is entitled Homeless Programs and Services 101 and is a companion to Homelessness 101, the session we did earlier. Today's learning objectives are on the next slide. And it is my pleasure and privilege to introduce you to our first presenter, Mindy Mitchell. Mindy?
Thanks, Chris. Welcome again, everyone. We can go to the next slide. I hope you all enjoyed that first installment of Homelessness 101. As you remember, that was a more broad overview of the important foundational concepts. So today we'll dive a little deeper, including looking into the various programs that exist to help end homelessness, determining which of those programs can be funded by ESG and ESGCV, learning more about housing first, especially since it is a required practice in California. We're going to dive into best practices for supporting people experiencing homelessness, and then talk a little bit about how to address stigma. Okay, so I'm going to spend the big chunk of my time talking about homelessness programs and services. And first, just a quick reminder, since there's so much confusion and frankly misinformation about it from some advocates, there are lots of definitions of homelessness as we discussed in the last Homelessness 101 session, and those are really about eligibility for different programs. So with the HUD definition, which governs ESG, remember there are 4 categories of eligibility. Category 1 is people who are literally homeless right now, either unsheltered or in emergency shelter. Category 2 is people who are imminently homeless or less than 2 weeks away from not having anywhere else to go, including people who are couch surfing or doubling up or living in motels. Category 3 is people who are defined as homeless by other statutes, but effectively who can stay there safely longer than 2 weeks. And then category 4 are people who are living in unsafe situations, including domestic violence, human trafficking, or engaging in survival sex. And as we talked about in the previous session, for scarce HUD resources, the greatest eligibility is for people who are unsafe or unsheltered, with gradually fewer scarce HUD resources for those folks who can remain safely housed for 2 weeks or longer. Okay, and as we also talked about last session, ending homelessness isn't just about one program or even a few different types of programs. It really does require what is usually called a systemic response to homelessness. That means that throughout the community and from all sectors of social services, we're building a system that makes homelessness rare, brief, one time. That means non-homelessness agencies and organizations are focusing on preventing homelessness, especially systems like child welfare and the criminal justice system, which can themselves become feeders into homelessness if robust support and exit plans are not implemented. Keep in mind too, what we talked about briefly last time, and I'll mention again, is that eviction prevention and homelessness prevention are not the same thing, since most people who go through eviction never actually become homeless. That doesn't mean there shouldn't be robust eviction prevention mechanisms in place in your community, just that targeted homelessness resources probably shouldn't be used for it. For people who are currently or on the verge of experiencing homelessness, we want to have in place a robust crisis response system. This includes temporary low barrier and housing focused shelter, you can click, but also robust diversion practices, which include having problem-solving conversations with people who are seeking shelter to help them find safe and supportive alternatives to entering the homelessness system at all. This is important to improve flow through the homelessness system by maximizing resources for people who have no other alternatives. But it's also important because no matter how good our homelessness interventions are, experiencing homelessness is traumatic, and people have better outcomes if they never have to go through that trauma at all. Next, an effective homelessness system of care includes system-wide coordinated entry. We know that many communities still struggle with coordinated entry, but as with definitions of homelessness, it's important to understand the reason why coordinated entry is necessary. Before communities began implementing this systemic approach to homelessness, it was all just individual homeless programs kind of doing their own thing. These programs were often high barrier and very selective about who they let into shelter and housing, which usually meant that the most vulnerable folks, the ones who were unsheltered, who had multiple barriers to stability, were left outside and unsupported. Not coincidentally, these folks were disproportionately people of color, especially Black and Indigenous people. So coordinated entry and that systemic approach to homelessness shifts the response to homelessness to the community, not just to individual programs. And it focuses on getting people who need housing the most into housing first and fast. Coordinated entry does that by creating a common way across programs to access homelessness resources, ensuring that the people who are least likely to self-resolve and who need housing and support the most to achieve stability are prioritized for accessing those resources. And those resources are permanent housing assistance through rapid rehousing or permanent supportive housing, or even just affordable housing in the community. Finally, we cannot implement and evaluate a systemic response to homelessness without good data. And that's where the Homelessness Management Information System, or HMIS, comes in. Good data allows us to track flow into homelessness and out of homelessness and who returns to homelessness. So we're measuring the performance and effectiveness of both our systemic response and of individual programs. Good data also ensures that we're doing all of that through an equity lens, so we can implement equitable and effective interventions for people of color experiencing and at risk of homelessness. Now, you all will be working specifically on ESG interventions, which include specific temporary and permanent housing, but it's always important to keep that entire system of care concept in mind, because we want all homelessness and prevention resources, including and especially ESG and ESGCV, to be working within and towards this larger systemic response. Okay, now I'm going to talk specifically about those different parts of an effective crisis response system. So first, there is homelessness prevention. I cannot say enough that eviction prevention is not homelessness prevention. So as we think about homelessness prevention that's paid for by the homelessness system itself, that needs to be much closer to the front door of the homelessness system. Prevention resources can be used for HUD categories 2, 3, and 4, and can fund important activities like rental assistance, other financial assistance, legal assistance, or mediation to help folks stay in housing, or other things like credit repair. While ESG and ESGCV can fund prevention activities, a much more effective use of those funds is to help improve system flow and actually end homelessness for people who are literally homeless or unsafe. There are many other community resources that can and should be maximized for prevention, including many other general COVID funding resources like the Emergency Rental Assistance Program, or ERA, that you may have heard about in your community. Additionally, the resources of other systems themselves, like child welfare, criminal justice, the anti-poverty programs like Temporary Aid for Needed Families, or TANF, those can and should be used to pay for housing for people who are in or exiting those systems or receiving assistance from them. If dedicated homelessness resources like ESG are to be used for prevention, it should be very carefully targeted to people who, but for that intervention, would become homeless. That is really hard to predict, especially at the individual level, which is why prevention is not the most effective way to spend dedicated homelessness resources, especially in places like many communities in California with high unsheltered populations. Next, a most important and effective part of a crisis homeless response system is robust diversion. Unfortunately, ESG and ESGCV cannot fund diversion, but as you can see, many of these activities are the same as those for prevention. So one could argue that the most carefully targeted prevention is actually diversion. But if you call it diversion, the funds you guys are administering can't be used, which is unfortunate. Diversion itself is simply having a good problem-solving conversation with folks who are having an immediate housing crisis and helping them find alternatives to entering the homelessness system at all. Now, this is not a denial of service. It's rather helping folks think through alternatives, which can be hard to focus on when you're in crisis, but it's also helping them connect to other resources that they might need to avoid becoming homeless altogether. This includes connections to supports, and that's really important because sometimes it can be done without using any homelessness resources at all, just that good case management. So here's an easy example. It's simple, but it's not uncommon, actually. Let's say that a young person is living with a relative, and that relative has just gotten fed up that the young person isn't contributing to the household budget, especially for food. So one day there's a blow up, the relative asks the young person to live somewhere else. When that young person reaches out to the shelter or to 211 or whatever the coordinated access point is, a diversion specialist starts having a robust problem-solving conversation with her. The specialist does some connection with that relative and finds out about the food budget issue, right? And she determines that the young person is eligible for but doesn't receive food stamps. Then that leads to a warm handoff referral to the food stamp agency, and that gets expedited because there have been partnerships in place between the two systems to make sure that gets expedited. Then the diversion specialist does a little mediation work with the relative and the client, helps them resolve that conflict, and talks about how the young person can now contribute to the food budget. Again, that's a really simple scenario, but those are exactly the kinds of crises that can lead to people losing their housing. So good problem-solving conversations can help resolve those crises and keep people in their own safe housing. And that's always a better alternative than having to enter the homelessness system, as long as we make sure that we're getting folks connected to the resources they need to maintain stability. Next up in an effective crisis response system is street outreach. This is a vital intervention for people experiencing unsheltered homelessness and includes developing a relationship with those folks, building trust, and connecting them to services, transportation, and other resources, including housing. So good outreach, like good shelter or good diversion, is always housing focused, always having a problem-solving conversation and meeting people exactly where they are. It's about housing first. It's about harm reduction, which Karen will talk more about later. And it's vital for reaching folks who are most vulnerable and who were least likely in our old way of addressing homelessness to get into homelessness programs. And the bodies of unsheltered people are often medically at least 20 years older than their chronological age. So good street outreach is literally a matter of life and death because being unsheltered is so damaging to health. It's also a matter of equity because Black and Indigenous people particularly are disproportionately represented among people experiencing unsheltered homelessness. So got to have good street outreach in place. Another thing to think about with street outreach is where you're doing it to make sure that you are reaching people of color who are experiencing unsheltered homelessness. I have just a little story about the importance of street outreach and doing it through an equity lens. There was a community many years ago that I heard about that did surveys of young people of color experiencing homelessness and asking them why they never came to the shelter downtown, why they never talked to the street outreach people. And it was because there's no transportation in their community to downtown. There was no way for them to get to shelter. Street outreach wasn't going to their communities, so they never met them and got them connected. So those are all really important equity considerations in street outreach. Next up in the crisis response system, and the one that we traditionally think about when we think about crisis response, is emergency shelter. This, of course, provides folks who are literally or imminently homeless or living in unsafe situations with a temporary place to sleep, indoors, out of the elements. But good emergency shelter also provides a lot of immediate resources that are designed to help alleviate the burden of unsheltered homelessness, like access to food and beds, place to keep your stuff. But most importantly, good emergency shelter is low barrier and housing focused, which we'll talk about in a bit. That means that that problem-solving conversation that you started in diversion continues even after folks enter shelter. It doesn't necessarily mean it's a conversation about getting into rapid rehousing or permanent supportive housing. We know that there are simply not enough of these resources in many communities for every single person who is in shelter to get them. So problem solving in the shelter context also means constantly helping folks think about housing alternatives that might be available to them, especially with friends and family. And those connections can include diversion resources like mediation, connection to services that will make shared housing more stable and supported. Now, I mentioned before that good emergency shelter is low barrier, and it's so important that I want to talk more about it, and it is an ESG eligible activity. It's also a matter of housing first, even though it's not permanent housing. It's a matter of that foundational philosophical response to homelessness. Low barrier means we're not screening people out of shelter, which is how things were in the bad old days before we begin implementing housing first and our systemic response to homelessness. Rather, we screen people in. We welcome them regardless of whether they have pets or partners or family, including people they consider family, and with their own possessions. We don't make people leave their stuff outside. Any rules that exist in shelter should only be focused on safety of other folks in the shelter, including staff. As a best practice, all shelters should be looking through their policies and procedures, their client handbooks, and asking of each and every rule that's in place, is this a legitimate matter of safety, or is it about staff comfort and convenience, or about controlling people who are experiencing homelessness? People in shelter, running shelters, should also look at what's come to be called in our field Marvin Rules. These are mostly arbitrary rules that were put in place for all clients because of some problem that happened with one client. And in the origin story, his name was Marvin, and it may have been about wearing a hat in shelter or using a lighter in the bathroom. There's different versions of it. But rather it's about, instead of implementing rules for everybody, it should have been just having a problem-solving conversation with Marvin about his behavior, and the shelter just ended up making a blanket rule for all current and future guests. So low barrier shelters also operate on a 24-hour basis and allow for a guest in reasonable manner to come and go, rather than implementing blanket curfews and lockdowns, which are, again, more about ease for shelter providers than what is actually most effective and engaging for shelter guests. Finally, though this should not be a major part of any community's homelessness system of care, I do want to mention transitional housing, since there may still be sometimes when it's necessary as a bridge situation to permanent housing. The thing about transitional housing is that it's time limited, and the program decides rather than the client when the client must leave the housing. This slide is actually incorrect, and we'll make sure that we correct it before we get the slides out, but there are folks who are in category 2 or imminently homeless who are also eligible for HUD-funded TH. Another thing about TH is that it's often high barrier and therefore screens out those folks who we talked about earlier that are actually most in need of assistance to exit homelessness and achieve stability. For those reasons, most transitional housing interventions are not housing first. By its very nature, transitional housing kind of assumes that people are not ready for housing and that they need something else before they can be successful in permanent housing, which is just not supported by the data. While some communities may find that some TH is helpful for special populations like young people or survivors of domestic violence, most community level data and other evaluations have shown that rapid rehousing is just as or more effective in ending homelessness and preventing returns to homelessness than traditional TH, and at a lower cost. So for that reason, transitional housing should not be a large part of any community's homelessness portfolio, and all communities should evaluate their existing TH, including talking to people experiencing homelessness about what supports they would need in permanent housing to ensure that they can achieve stability. Okay, so that was a long overview of all the parts of the crisis response system. Now I'll go into the main permanent housing interventions in an effective homelessness system of care. So the first and most important intervention, and what should be the main part of your homeless systems portfolio, is rapid rehousing. Rapid rehousing includes 3 core components: housing identification, rental assistance, and case management. The housing identification piece is really important. And this training series that you guys are getting includes a lot of rich sessions on landlord engagement, recruitment, and retention. But for now, I'll just say that that core component of rapid rehousing, housing identification, should be the responsibility of the program and the system, not the client. People experiencing homelessness have enough on their plates without having to worry about trying to find a landlord and convince her to rent an apartment to someone who likely has some barriers to being approved for rentals. Things like poor credit history, previous evictions, even a criminal history, all of which happen to people of color disproportionately and which lead to disproportionalities in homelessness. So with all of these interventions, doing this well is a matter of equity. The second core component of rapid rehousing is rental assistance. In most HUD programs, this assistance can go for up to 2 years, but national data indicate that average length of assistance in rapid rehousing is 4 to 6 months. That average time can go a little longer for some populations, like young people who are likely just getting started in their housing and employment journeys and may need assistance for a little longer. Most importantly for rental assistance in rapid rehousing is practicing progressive engagement. This just means that rather than having a blanket amount of assistance for every single rapid rehousing participant, that assistance is tailored based on the needs of the individual household, as demonstrated by that household with regular check-ins about income and other resources. And that enables you to determine if that household will need continued rental assistance, or if that assistance can be tapered up or down, or even ended when someone's ready. Finally, the third core component of rapid rehousing is case management and services. And as a former case manager, for me, this is the secret sauce for making rapid rehousing successful. Good rapid rehousing case management keeps in mind that while the housing itself is permanent, this is someone's own apartment with their own lease. They have all the responsibilities of tenancy. The clients don't have to leave, but the rental assistance will end. So at some point, we want to make sure that rapid rehousing participants are connected to all the resources in the community that they're going to need to maintain housing stability. This includes things like those anti-poverty resources we talked about earlier, TANF and food stamps. It includes connections to healthcare and childcare and transportation, and also connections to informal community-based resources that ensure social support, which is, if you think about it, what all of us rely on in our own lives to ride out struggles. A newer part of the homelessness system of care is the joint component. This is not a part of the ESG or ESG-CV portfolio, but we'll mention it here so that you're aware of it. This is just a way to fund temporary housing to get people off the streets while they're waiting to get into rapid rehousing, essentially. The TH part of this joint component effectively functions as shelter, though participants can decide how long they stay in the TH part before moving on to the rapid rehousing part of intervention. And finally, we have permanent supportive housing, or PSH. This is also not something that ESG or ESG-CV funds, but it's something you should be aware of because so much of the homelessness system's funding, especially that in the COC, is tied up in this intervention. PSH provides a permanent housing voucher and long-term, often on-site services for people with disabilities and long time or multiple experiences of homelessness. Because PSH is so expensive and potentially for the rest of someone's life, it should be very carefully targeted to people who are experiencing chronic homelessness, which we talked about in the last session, or who have demonstrated through extensive progressive engagement efforts that a shorter term or less costly intervention like rapid rehousing is just not going to help them achieve housing stability. Okay, so as you've heard me mention throughout, while all of these things are important parts of the effective systemic response to homelessness, Not all of them are funded by ESG or ESGCV. You all will be focusing on those eligible activities, but as we keep saying, these all should be funded and evaluated with the entire system in mind and how the programs themselves contribute to or inhibit the ability of the community at large to perform well on the outcomes of making homelessness rare, brief, and one time. And before we move on, as I mentioned earlier, while diversion itself is not a funded program component for ESG or ESGCV, the problem-solving conversation and activities of diversion are and should be a part of all those other funded components. Again, before we move on to Karen, I cannot say this enough because housing ends homelessness. All of the activities in our systemic response should be focused on getting people into or keeping people in permanent housing and doing that as quickly as possible. So all of our homelessness programs are oriented towards and focused on moving people into and keeping them in permanent housing. Regardless of the program component, they all should include strengths-based case management that focuses on things like creative problem-solving conversations, conflict resolution mediation, housing advice, help with search and placement, housing stability case management, really important. Landlord-tenant mediation if you don't have someone who's a dedicated housing navigator. Always connecting folks to mainstream resources to ensure stability, including things like legal services, making sure that folks who are undocumented or who are working on immigration are connected to legal services. Also think about connecting folks to fair housing. We know that tenants of color, especially Black and Indigenous folks, experiencing more housing discrimination, this can lead to returns to homelessness. So that's a really important resource. Helping folks get connected to things that can repair their credit, learn how to do effective budgeting and money management, and of course, education and employment resources. All program components, regardless of any of those I just talked about, should include or at least be able to make connections to different kinds of financial assistance, including application fees for rentals, those rental subsidies, paying arrears, security deposits, utility arrears, all of these are eligible funds, moving costs, transportation costs, helping people get cars repaired, other critical family needs, and just general financial assistance. Again, always having those problem-solving conversations to see what's going on in folks' lives and how they can get connected to the resources they need. And finally, before I turn it over to Karen to do a deeper dive on best practices, just wanted to give you guys a few simple examples in each of the potential interventions that we've just talking about, what being housing focused could look like in each of them. So for example, if someone is in shelter and the problem solving conversations didn't come up with alternative resources based on that guest's own network, the shelter worker then connects the guest to coordinated entry to get the process started on a homelessness system funded housing intervention like rapid rehousing or PSH. In street outreach, if during the problem solving conversation, a street outreach worker determines that someone wants to live with his children again, the outreach worker can connect with family and children's services, find out more about what's going on with that situation and how family reunification can help happen. And then finally, good case management and rapid rehousing is focused on maintaining that housing after assistance ends. So the participant wants to work to make that happen. Even while housing location is happening, that rapid rehousing case manager can work on making a warm handoff to connections in the employment support system to ensure that that resource is being used immediately and that folks are getting connected to what they're going to need to maintain stability in the long term. Okay, that's it for me and all of the pieces of an effective systemic response to homelessness. Now my colleague Karen will take you on a deeper dive into best practices in implementing that important work. Go ahead, Karen.
Thanks, Mindy. Thanks everyone for joining us today. I'm excited to talk to you about some best practices. So we're going to review the following best practices, which are housing first, motivational interviewing, harm reduction, and trauma-informed care. All of these are evidence-based. There's lots of research in the world about how effective all of these interventions are. So if we did not include that in this presentation, but if you want some resources, I'm sure we can find some for you. So housing first is on top because really it's the let's see, could you guys go back to that? Sorry. It's the overarching practice that addresses housing as a solution. It's about how and when people enter housing and how we help them maintain it. But housing first, as Mindy has mentioned a few times already, isn't just about working with people experiencing homelessness and getting them housed. It's really our overall orientation to the homeless system and our overall approach to ending homelessness, that housing is the solution in all aspects, whether it's shelter or in permanent housing. So motivational interviewing, harm reduction, and trauma-informed care are typically used, I would say, to help participants achieve their goals and assist them in maintaining their housing. But we do see that they're also very effective in assisting people in getting into housing, helping them reach those goals and overcome things in order to get into housing. So we're going to talk a lot about housing first. All of these could be their own training. So, but housing first is really important. So we're going to talk a lot about that now. And so this first slide on housing first is really a quote from HUD about the housing first approach. I'm just going to read it aloud because I think it's important to what we're talking about. So housing first is the approach where homeless persons are provided immediate access to housing and then offered supportive services that may be needed to foster long-term stability and prevent a return to homelessness. This approach removes unnecessary barriers and assumes that supportive services are more effective in addressing needs when the individual or family is housed, when the daily stress of being homeless is taken out of the equation. So we've already talked about homelessness as being traumatic, so housing helps reduce that stress in a very immediate way. So with housing first, there's 4 overarching principles that we like to talk about. Again, housing first removes barriers to housing and retains and prioritizes the most vulnerable and high needs people for housing assistance. So these principles are really important to housing first. First of all, that homelessness is a housing problem. It's a problem because people don't have a home, and we should treat it as such. It's not a problem like we mentioned in the previous training of mental health, substance use, or all these other things. The problem is people don't have a home, and we need to get them into a home. So the next one is people should be stabilized in permanent housing as soon as possible. So we want to rapidly put folks in permanent housing as soon as we can, and then connect them to resources to sustain that housing. So as we mentioned before, we see entry or being housed as a clear path to improving health and other aspects of one's life. So with that, the underlying issues that may have contributed to someone becoming homeless are best addressed when someone is in stable housing. So we do see folks who are able to manage employment or manage their mental health or substance use disorder while homeless, but really we see most effective management is when folks are housed. And the final one, and probably one of the most important ones, that everyone experiencing homelessness is housing ready. We don't have to get anybody ready to go into housing. So if that was too jargony for you, talking about this in some regular language is that, we accept everyone regardless of their sobriety. Participants are supported in ways that meet their individual needs, not our needs. We don't evict people because they're not complying with a service plan or some rules that we've established for them. And participants aren't required to take classes before being placed in housing. So this was something, all of these things were things that happened, in the past. And we've realized that these, having sobriety, putting our needs in front of the person's, terminating people because they're not complying in some way, and making them take a class. These are all things that we found are not effective in helping folks obtain and maintain permanent housing. So when we're talking about housing first, and now we're moving into the California law or rules on this, but really this mandate in California really is showing a systemic approach, and it's incorporating housing first throughout the homeless system. So this means that the continuum of care has written standards. So these are standards that refer to any of the programs and how they should be administered and compliance with those. And so Housing First needs to be embedded in those standards, which go across the system and across funding sources. We see in California that state funding housing programs also are incorporating Housing First and these rules into their contracts and how they want these programs administered. And then we're also seeing that even down into ESG and how the federal and state laws are applied for Housing First. So throughout the system and throughout the program models, Housing First is important. So we are going to go through these components of Housing First that are in the California state law. I've tried to group them in kind of ways that make sense, but they are in the order in the state law. So these first three components for me are really about how folks are how we're entering people into housing programs. So this is about housing readiness. And remember, everyone is ready to be housed. So no one has to be sober or prove that they're part of a treatment plan, whether it's for mental health or substance use, in order to get housing. I mean, in the past, this was the case, right? And what did we find when we required people to be sober or to be adherent to a treatment plan? We found that they couldn't be successful, so they became homeless again, and they were coming back to the system. So it encourages cycling through the system, which we know isn't beneficial. And it also resulted in more people being homeless and for a longer period of time because they couldn't get acceptance into programs because they couldn't meet the standard of sobriety or treatment adherence. We don't reject people because of their past. So there's lots of reasons why people are rejected. It could be their rental history, their credit history. It could be lots of different things. So we don't look at someone's history or hear someone's history and say, no, we can't house you. We work harder then to find a landlord who will work with us in order to house that household regardless of their past history. So we work together. So this last one is really, I think, about the system and how we're working together to end homelessness. We're not taking whoever comes to our office and says they need housing, which was what happened in the past, so that we're prioritizing people that no one else knew about. We want to house the people that are in our system that we know need housing. So lots of people, you may hear in communities, they talk about creaming or cherry picking. So they worry that providers are still doing these things. And so, they want to do this because they wanted to feel good about their success, but by having them feel good, lots of people were left out of the housing system. So we don't encourage this kind of cherry picking or creaming of having the people who they think will be successful or easy to house as part of their programs. So then the next set of components is really, for me, of how we work with people and how we keep them housed. And so the first one I would say, part of this, is that people know themselves the best and they know what they need. When we help folks work towards their goals, which are theirs and not ours. So we want the client or the household or the people to be the drivers of their own plan. And we really do this by working together, by solving and overcoming problems. So there's no us as the provider telling someone what they should be doing. We work together to figure out what's the best course of action to resolve problems and to achieve their goals. And this is really a pace that people do. They set themselves and they set it on their terms, and the steps may be really small, but those are the steps that are important for them. So the participation in services, when you hear folks talk about Housing First and what they don't like about it, they don't like the fact that there isn't a requirement for participation, but that isn't to say that there can't be an expectation that people participate. It's just that, unlike in the past, when people didn't meet that expectation, they were terminated or evicted from the program. Not participating isn't a reason to have somebody terminated. It's really a reason for the provider to work harder on how to engage them and how to make it a meaningful conversation about what they can do together to achieve goals. I think one important part of these four is that homeless people have rights just like everyone else, and that they should have their own lease. So They have the rights of tenancy, they have the rights to a home, and they have the responsibility of that legal code for having a lease. And then again, just to reiterate, because I don't think we can reiterate this enough, that bad behavior is not, or behavior we don't like, is not a reason to terminate or evict someone. So really, under Housing First, things like, that may get people on the verge of eviction, this is really not an opportunity to terminate someone. It's really an opportunity to learn and grow and understand what's going on and how some changes could be made in order to keep folks housed, because the reality is we're all humans and we all make mistakes, and we should look at that as a learning opportunity. Now we're getting into the heavier, wordier parts of the rule, but these two I think are really, for me, about how our system works and can be housing first. So the first one is about coordinated entry and how we're coordinating and making sure that those have the highest needs are getting housed. Again, back to the idea a couple of slides ago about creaming. So programs and projects should not be housing those who come to them or ordering them on a first come, first served basis. We've learned that this, as a result of this, we have more and more people getting housed, and the highest need people are not getting housed. And then in regard to racial equity, there's disparities when we don't house people in a systemic and equitable way, which is what coordinated entry does. And the last one on this page is that really confirmation from the state that we need to engage and assist people in practices that work, and that we're focusing on the person and the person's goals. And we'll go into some of those evidence-based practices in a minute. And again, the last two are really, again, about how we treat people. We'll go into harm reduction. We want to use non-judgmental approaches towards addiction, and harm reduction is the way to do that. And we want to ensure that everyone can live in an apartment independently. So this can include making reasonable accommodations for people with disabilities. This can include ensuring that when we house people, we're housing them in a part of our community where they do not feel threatened or and can maintain their goals. So some folks don't want to live in certain parts of a city because that's where they were using, right? And so they don't want to go back to that neighborhood, or they've had bad relationships there and they want a fresh start. So those are some of the things we need to think about with accommodation. So to sum up with Housing First is, again, housing is a tool. I would say it's more than a tool, it's our solution. So by housing folks, we are ending homelessness. We want to rapidly connect folks to housing. So this is putting them in housing as quickly as possible. And in order to do that quickly, we have to eliminate all of the barriers. So that's why we don't have barriers about sobriety or treatment adherence or clearing somebody's background before we house them. Those things just slow down the process of housing folks. Services are available and optional. Those of you who may have heard other Housing First trainings, these are often called voluntary services. I don't like the term voluntary because I think it gives providers an out for not providing services. So I think services should be available and optional, because we want the balance to be on the provider in order to have engaging and effective services that people want to participate in, and that they're always available for them whenever the participant wants to engage. So they have the choice of engaging, they have the choice in how much or how little, but really the provider is the one who's trying to make sure they're engaged and keep them engaged and keep them moving and help them move forward with their goals. And then finally is that there's no contingency of participation in services. So no one has to participate in services, but again, the onus is on the provider in order to ensure that there are things that someone wants and they do want to participate in, but there's no harm to the participant if they don't participate in services. So I'm just repeating this slide just for myself so that to remind us that we're going to go through three more best practices. I just wanted to let people know this is really a high level overview of each of these practices. This isn't going to be an in-depth social work or clinical definition or perspective on these. I personally am not a clinician, so I generally talk about these things at a pretty high level, but I do want you to understand the concept of each of these and how it can assist people in reaching their goals and making change in their lives. For each one, we're just going to pause for a minute before we go into it, because I really want you to think about maybe a similar situation in your life and what has helped you to achieve your goals or make changes in your life. Not all of us, need help from someone else to help make a change, but the concepts, hopefully the concepts and the orientation with these best practices will resonate with you of how change can occur and what's been most effective for you to make changes in your life. So the first one we're going to talk about is motivational interviewing. And so for this one, just think for a minute about your life and some change that you've made. This doesn't have to be anything big. This could be something about, being more organized or getting a new job or eating better, something with work-life balance. So think about what that was. How did you know you wanted to make a change? Did someone tell you that you had to make that change? What helped you make it? And what kind of support did you need while you were going through it? So just take a couple of seconds to think about that. So let's start talking about what motivational interviewing is with this idea of what this change was in your mind. So really, the goal of motivational interviewing is really to help someone in working towards their goals and solving, working through their own challenges and the things that kind of are hindering them, their ambivalence maybe to change, and helping them towards a solution, but not giving them the solution. So we want to, work and reinforce the motivations that folks had for change and how they can do that. So this is really, I like to think of it as kind of a guided conversation or guiding someone towards a change. When we do motivational interviewing, we're not telling someone how to change or what to change in their life, but they're telling us what the change is that they want and why they're motivated to do that change. And we're helping them work through the change process. So some of you may know that there's various clinical stages of change. So that's a really central part about motivational interviewing, these stages of pre-contemplation, contemplation, preparation, action, maintenance. You may know these if your background is clinical or in social work. And so working through these stages of change. So how we see that when we're working with in motivational interviewing is really change talk and listening for the talk that people have that they want to change. And really when motivational interviewing is implemented, the case manager or the practitioner is really someone who's actively listening and trying to understand someone's motivation to change. So that active listening part is really important because we're listening with empathy with their situation and trying to understand. And then what we're trying to do is empower people to make that change. So we're giving them confidence, right? And we're giving them confidence so that they can succeed. So with this graphic, they have this desire or ability or reason they want to change, which goes to their commitment. And then together you're working with the commitment and what steps they're taking to see what kind of behavioral change they can make or what kind of change in their life they want to make. So generally, we're not telling folks what to do, that we're doing this by trying to determine what success looks like for them and how they're going to get there. And so sometimes this can be very incremental steps and incremental ways in moving forward. So, how is motivational interviewing different? So really for me, and when it's most successful, motivational interviewing is a partnership, and that partnership is equitable. So unlike other ways that clinical sessions can happen, there sometimes is a hierarchy and one person is maybe imposing what they think is the right thing to do or telling someone what to do. That could be your personal experience. Sometimes a change it really is equitable, and their key inputs from in order to make the change in the conversation is really coming from the client, because they're the ones who have the motivation to change. They're also the ones who have their own expertise, goals, and views, which are really important to the process and understanding in order to help them move forward and understand how their past affects their ability to change and what they've learned from the past that they can bring forward. So this focus is making on informed choices. So we're sharing information, we're sharing resources with them, but they're the ones in control. They're in control of the pace, they're in control of the steps, and we're really actively listening, understanding what they're saying, reflecting back to them what we've heard, and seeing what the path forward is. So this isn't a session that someone is telling someone else what to do, or motivating them through some other success. So sometimes when we're looking to make a change, someone will be like, oh, hey, look at what, so-and-so did in order to do the same thing. Why don't you just do that? And often we know personally as well that how someone else did something isn't necessarily the best way for us to do it. So motivational interviewing is really helping folks through guided conversations and guided practices of understanding what change they want to make, how they can make it that works for them, and what are the steps they need to do in order to do that, which you'll see, I think, is a similar theme with other best practices. So let's move on to harm reduction. So again, we're going to pause and reflect. You may have the same thought as you did for motivational interviewing, but usually with harm reduction, we think of, like to think of things that you want to stop doing, specifically things that may have been unhealthy. This could be, maybe it's dieting, right? So that's an example that lots of folks use sometimes. Maybe it's if you want to stop smoking or some other unhealthy behavior that you would like to change. So what was that behavior? How did other people make you feel about it, right? Sometimes we hear that there's shame sometimes in certain behaviors. Did someone just tell you or think that you should stop doing it, just kind of going cold turkey with something? But in the end, what really helped you change and what kind of support did you need? This doesn't need to have to be some major change, but I think we all reflect on our lives and want to change unhealthy practices that we might have. I'll give you a couple seconds to think about that. Okay, so what exactly is harm reduction? So some people, when they hear the words harm reduction, their thoughts automatically go to it solely being on stopping drug or alcohol use, which is true. Most of harm reduction is about stopping drug or alcohol use, but really it's actions, policies, programming that is for any harmful behavior. So really harm reduction started with needle exchange programs, right? It started with how do we curb the spread of HIV by ensuring that people are using clean needles and not sharing needles. So there was some emphasis on reducing usage, but really the start was really what's the safe usage so we can reduce the harm of contracting HIV. So there was an acknowledgement of the safety practice for people who are IV drug users. This is an example of it's not necessarily stopping the drug use, but it's other harmful things that can be associated with that behavior. So this can be used for any type of harmful behavior or addiction. So sometimes it's regarding, sex addiction. Sometimes it's regarding food addiction. So some folks only talk about harm reduction in relation to alcohol and drug use, and that's simply a little bit of a narrow focus on that. So in general, we see that harm reduction is a non-judgmental approach. So we're not putting any judgment of how we feel about that practice, whether that practice is good or bad, or that someone should stop. But what we do is we're giving folks knowledge, skills, and resources to help enhance and make informed decisions about that particular behavior and what they want to change about it. So the focus with harm reduction isn't necessarily stopping, it's reducing the harm. And so we need to, folks need to be informed so that they can choose the best way to manage that risk. I think it's important to note, like we've mentioned before, with why people become homeless. There's many people who are engaged in high risk and risky behaviors, and they do not become homeless. They do not have the harm to themselves that others do that we see in the homeless population. So just to keep that in mind, there's lots of risky behaviors. That doesn't mean that they're wrong. That's why we take a non-judgmental approach. But we want to talk with people and see how they can choose to manage that risk in a way that is effective for them. So harm reduction, we found, can be implemented really everywhere throughout the homeless system, throughout our communities. So it's, housing providers and supportive service providers taking a harm reduction approach, like we see, with shelters, some with low barrier shelters, some of them, allow people to use within the shelter or use in a certain part of the shelter. Mental health providers, and then policymakers. So, we see sometimes how, not implementing a harm reduction approach can have real harm, right? Like some of you may have heard a few years ago, there was a huge outbreak of HIV in Southern Indiana because their policies on clean needles did not exist. And so people were sharing needles, and they had this rampant increase in HIV. So sometimes our laws are really do not have a harm reduction focus. So that's another area where we can implement harm reduction and implement change that's positive for the homeless population. So some of the key characteristics of harm reduction, are of course removing barriers, as we've talked about. This goes right in line with housing first, and that we're not minimizing or screening people out based on their high risk behaviors. We're not requiring abstinence. We have this non-coercive engagement. So this is really where motivational interviewing comes in, and that we're communicating with folks in a respectful and non-judgmental way, and we're working with them through the stages of change that they want to implement themselves. Again, like with motivational, all this, the services for harm reduction are client driven. So we need to understand the client's goals and their capacity for change and what they want to do. So we're flexible in our intervention, we're flexible in how we're approaching things. We're focusing on their immediate needs. So this means setting realistic and attainable goals, which is why it's a conversation. So if someone imposes a goal on you, it's often not realistic and it's or attainable for what you can do. So again, small steps, just like with motivational interviewing, is part of harm reduction. So really we're celebrating progress on small goals. And so harm reduction is not about quitting cold turkey or stopping something immediately, unless that's the person's goal, of course, but often it's about small steps, about changing someone's use. I mean, so a former, someone that I know as a participant was in a transitional housing program, and they really struggled because they kept relapsing, they kept getting kicked out and coming back and getting kicked out. But the most effective thing for them was to be in permanent housing, because when they were in permanent housing, they actually had a case manager that understood harm reduction and really helped them reduce their use so that they didn't become homeless again. They could use in a manner that was supportive of their lifestyle and supportive of the other things that they wanted to do. So they were able to repair their relationship with their children, maintain housing, do community service. So all the things that they had always wanted to do, but still was able to manage their use of drugs. So, and they celebrated these small successes along the way. I heard them speak a few years after I had known them. And that was one of the things that was really important, was that it was really small goals that led to this larger success. And part of their success was information education, because where they were at before didn't have a harm reduction orientation. And so learning strategies and being educated and getting tools and resources in the community to help reduce that harm was really important. And the strong relationship that person had with that case manager showed, because they spoke together and you could just tell how connected they were and engaged they were in each other, and how invested they were in each other's success and whatever success meant to them in that moment. The other part is, this acknowledgement of personal responsibility, is setting up practical expectations as opposed to rules, right? So, lots of people have challenges with rules, but like setting an expectation that's practical and attainable, it really helps move things forward. And then understanding natural consequences. So high risk behaviors do have natural consequences, and understanding those, and then how that can help move someone towards change. And then community partnerships. This is linking folks to providers or treatment or needle exchanges that work for what they're doing regarding their harm reduction, their plan for harm reduction. Okay, so let's pause for a minute on trauma-informed care. This is our last best practice. So really this one is really a time of when you've experienced something that has caused you a high level of stress. Often we think of this as a loss of some sort, whether it's a job or a person, some sort of accident. So what was that high stress event? How did you feel? What did you do to move through this period? What helped you, and what kind of support did you need? So I'll just pause a couple seconds on that one. Okay, so let's start talking about trauma-informed care. So I think what is trauma? I mean, let's just start with something simple. So trauma is an emotional response to a terrible event in general, like an accident. It could be very traumatic, like a rape or natural disaster. And usually when we talk about trauma, we talk about kind of three main types. So there's acute trauma, which is from a single event. There's chronic trauma, which is represented by repeated or prolonged events. This is what we often see with abuse or domestic violence. There's a complex trauma, which is exposure to varied and multiple traumatic events, and it often is seen as invasive and impersonal. So those are the three types. I mean, I think, the first step with trauma-informed is recognizing the presence of trauma symptoms and acknowledging the role that trauma plays in folks' lives. And we know that for folks experiencing homelessness, that homelessness is a traumatic experience, and that homelessness and trauma are very interrelated, and that trauma, especially and really in any three of these, but especially with chronic and complex trauma, it overwhelms somebody's ability to cope, and it impacts their decision making as well as their emotional, relational, and cognitive functions. And so how folks are behaving is an adaptation of their past threats. So what does it mean when we have being trauma informed? So what we're doing here is we're really creating, first we need to understand what trauma is. So that's the first part, but then we're creating responsive services and programs. So we're taking this orientation throughout our programming. So the main key to that is really avoiding re-traumatizing people. So we need to understand what trauma is, understand how we can create a responsive program, because we really don't want to re-traumatize folks who are receiving our services. And then the next step is really helping them towards a path to recovery and healing and better health. So how does that look as compared, how does a trauma-informed approach look as opposed to a more traditional approach? So as you'll see from this chart, many of the things we've talked about, we've already discussed either in harm reduction or motivational interviewing, or even in housing first, is that being trauma-informed shifts the power dynamic. So the power is shared. There isn't a hierarchy and one person above another telling them what to do. This hierarchy is greatly decreased. We really emphasize that people are experts in their lives and they're experts in their experiences, and that they're really partners in problem solving and partners in developing a plan to recover. And so this, with trauma-informed care, you're really focused on recovering and healing and creating an atmosphere where people feel they can recover and they can heal because they don't have the fear of being re-traumatized. Also, being trauma-informed acknowledges that there isn't a specific symptom or things we can reduce to make someone less, the experience less traumatic. So we help them create skills in order to heal and to manage with their recovery. So it's a very proactive approach. It's not waiting for something to happen and then reacting to a crisis. So we're working in a proactive way to ensure that further crisis doesn't occur and that we're avoiding re-traumatizing people. Again, like with all of these best practices, we're providing people with choice and autonomy and control. And this is really central to any type of healing, but in the trauma-informed approach, that's really central. So as I mentioned earlier, all of these practices really are interrelated and work together. So you don't just like pick one and say, oh, we're going to just be trauma-informed and not anything else. You really can't necessarily be very trauma-informed if you're not also using motivational interviewing and listening to people and having that active listening and responding to them in that way. It's hard to, when you're working with someone who has some addiction issues, to not look at that. Again, harm reduction is also a pathway to healing, right? And how they can avoid crises and harmful situations. So I'm going to move on to addressing resistance. So this is the last part of our presentation. If I'm sure as citizens of the world, you've heard of and know about stigma towards different things, but especially around homelessness. So often we're talking about NIMBY, which is stands for not in my backyard. So this idea that we don't want either homeless people or homeless programs or homeless things in our backyard. But then we get to this question that this photo shows of, if it's not here, then where will we have these things? So when we talk about stigma and how to address it, I mean, I think for me, stigma really regarding the homeless population really manifests itself at 3 levels. So we see it towards individuals. So, right, someone may see a homeless person on the street and feel these feelings of stigma and negative feelings towards homeless individuals. We see it with programs, right? Sometimes someone wants to build a shelter or a housing program in a certain neighborhood, and or there is a program in a neighborhood and they see people like hanging outside, and neighbors don't like seeing that, and so they have real negative feelings toward that program. And then as a community, right? So I think often in California especially, we hear about whole communities really being concerned and not wanting to have homeless folks in their community because no one wants to see their neighbors be homeless. So what are some of the ways, and this is a collective problem with the community, how do we address this collective problem? So how do we address any of these 3 levels? So with individuals, that's really looking at the services provided to them and how they have access to those services. So whether, like, what services might be available in your community to them. Sometimes it's really like, is there a clothing bank that they can get clean clothes? Is there a shower or a laundry service that they can go to? Is there a PO box, right? So folks need to get their mail. So if they can't get their mail, they can't move out of homelessness. So these are some of the things that we can look at and think of, like, what services are in our community that can help people feel that people are getting served. So regarding programs, I mean, there's lots of different ways to reduce stigma about programs. So one of the ones that I hear most frequently are site visits from local leaders. So having your alderman or your, that's what we call them where I'm from, alderman come to your shelter or your homeless program to understand what it is, who they're serving, what's happening. I know in some locations, they do open houses, especially with like local law enforcement, so they can come in, see the program, see what's happening. So then when they see somebody outside or on the, outside or near the facility, instead of just arresting someone, they can call that particular program and understand what's going on and help, with that goodwill and things like that. And then finally, with the community, there's different ways that communities have tackled stigma. So some communities, instead of having a shelter in just one neighborhood, they have a lot of smaller shelters throughout the community, so that every neighborhood in the community may have a small shelter, so that it doesn't feel like one community is disproportionately having all of the homeless services in their community. Safe parking programs is another thing. So, some folks are living in their car, and so how can we have them safely be somewhere overnight? So this is another way that communities have addressed some of the stigma around homelessness. And then public forums, so talking to each other, hearing what the concerns are, and then working towards addressing them. I did find a couple interesting examples with tiny homes. So tiny homes feel like all the rage about how to end homelessness. I'm not sure that's true, but I think these examples are interesting in how they approached working with the community to combat stigma and NIMBYism of not wanting these projects in their particular neighborhoods. And so both of these examples really talked to people early, even before the project was going to take off. And this included having local officials go out and talk to people. So it wasn't just the homeless program provider going out and seeing what people thought. It was really people in charge talking to people and having and hearing their concerns and also responding to them. So I think the response part is critical, right? So we don't want to, people just don't want to have feedback sessions on what they don't like about the homeless situation. They want to be responded to as well. I think it was also interesting in San Jose how they really kept the conversation going. So they, still have this community advisory committee, and they meet monthly and keep addressing concerns about what's going on in and around that project. So as you can see, one way to, combat stigma on the community or the program level is really effective, targeted communication, so people understand what's happening before it happens, but also that they have a source to voice concerns later on as well. So as we wrap up, we just wanted to give you a few resources. These are a couple more programs, not related to stigma necessarily, but programs that work. So if you're interested in what an effective street outreach program could look like, or a low barrier shelter example, that's good. These are ones. We also did some just general homeless programs. So the Bay Area Bright Spots are different types of housing programs around the Bay Area. So it includes counties and not just San Francisco. And then we hope you're all aware that Riverside in California was the only place to end veterans homelessness. So they've reached this functional zero. So any new vet that comes into their community, there's resources available to them so they won't be experiencing homelessness. So one, it's absolutely possible. I know sometimes we don't believe it's possible to end homelessness, but it is. So it is possible, even in California. They took a systemic approach, and many of these housing interventions like rapid rehousing and permanent supportive housing work in ending homelessness. So if you want to read some good stories of positive outcomes, those are some for you. Thanks.
Thank you, Karen, and thank you, Mindy, for your presentations today, and thank all of you for attending this California Housing and Community Development Training Session offered through the Emergency Solutions Grant, Coronavirus Relief Consulting and Staffing Services Contract. Please note that this training series features over a dozen sessions that you can view at your leisure.